Dr. Michael Sauter is brought to you by Marcus & Mack, a law firm representing injured people. Dr. Sauter with us this morning as we talk about stroke. Indiana Regional Medical Center is a primary stroke center, and we had you on last year at about this time. May is Stroke Awareness Month, and it certainly is a serious topic and not made less serious by the fact that we've been in this pandemic. This is something that always needs to be at the top of our minds, does it not?
Yes, absolutely. With the COVID, we found an increase in stroke and other vascular conditions, not as critically severe as, of course, the lung issues, but nevertheless, there was about an increase of 5% in terms of strokes related to COVID patients. So it can still be a devastating injury on top of a terrible infection.
Now, IRMC being a primary stroke center, what does that mean in terms of what is available at IRMC as opposed to others that are not in that categorization?
Well, what it shows is our level of experience and expertise in processing patients efficiently and effectively. What our goal is to primarily stabilize the patient and determine if they qualify for a clot-busting drug called TPA. Mm-hmm. That's generally given within 0 to 3 hours of the onset of symptoms or up to 4.5 hours of the onset of symptoms. So if we can give them TPA, we feel that we can make a major inroad into helping them to recover from the devastation of their stroke. What we also try to do is evaluate that patient to see if they need further treatment in addition to TPA, that being a thrombectomy, where they do essentially a catheterization of the brain blood vessels and then snare the clot and pull it out of the blood vessels and then allow reperfusion to occur. So for that condition, we need to send them into a comprehensive stroke center in Pittsburgh, either at Allegheny General Hospital or Presbyterian University Hospital.
One of the interesting things to me through the years when we've been talking about stroke, there are two types of stroke. And in both of them, the ability to recognize and act quickly is extremely important. In fact, there are some acronyms. And I know the one FAST, and we're going to talk about that, but there are two others that use that same sort of a concept. Tell me about FAST first.
Yeah, they all three really center around identifying symptoms or signs of a patient's decline and reacting quickly. Mm-hmm. So, for instance, the FAST acronym goes into facial changes, that is asymmetric facial weakness, arm weakness, and speech problems, either aphasia, where you're just speaking gibberish, or dysarthria, different areas of the brain affected with either dysarthria or aphasia. Mm-hmm. Okay, but and then T for time to respond using 911 as your immediate response intervention. So that's the FAST acronym. But again, the whole purpose of it is to say if you have one-sided deficits, it's likely a stroke, and you have to respond by calling 911 as quickly as possible.
I recall you telling me last year, doctors never are concerned if it turns out not to be a stroke. They're concerned if it was a stroke and you didn't act in time.
Right. I mean, it's everybody's inclination to deny. And so that's not a criticism. It's just a logical explanation that what's happening to me isn't real or it isn't permanent. I can just sit it out and it'll get better. But that's not really what we want to encourage. We want people to call 911 and to bring them into the hospital and let us make that determination before time runs out on that 0 to 3 hour window or that 3 to 4.5 hour window.
So the first one was FAST. What's the next acronym?
The next acronym is FASTER. Okay, and that again starts with facial asymmetry or weakness on one side, arm weakness, just as before. Stability now talks about balance. And this really refers to back of the brain stroke, balance or gait instability. And then T now goes to talking. Is your talking pattern different? And then E for FASTER goes into eye movement or vision disturbances. And then R goes into response or reacting by calling 911. So again, in each situation, we're saying, look for something asymmetrical or different than your baseline and react. by calling 911.
One of the interesting things about all of this as well is you're, in many cases, going to have to rely on the people around you to notice these things. You might not even have the ability, if a stroke is occurring, to react the way that you should. So the people around you have to be really on their toes.
Tremendously important point to bring out that caregivers are the heroes. Mm-hmm. Without a doubt, they are the heroes because they see something, and just like you say, the patient may not be aware of it or able to respond to it, and it's the caregivers who get on the phone or get the patient into the car and get them to the hospital. We would prefer them to use 911 and to use our citizens ambulance service.
Yeah, absolutely. And, you might not be a caregiver until that moment when you recognize, and then you transition into Superman.
Absolutely. I mean, you can be a family member, or you can be just someone in a restaurant or at the mall noticing that something just happened. Yeah. And then calling 911 to enlist the support of professionals.
So there have been 2 acronyms we've talked about. Yep. There is a third.
The last one is Be Fast. And here, again, we're talking about BE. B is for balance. Mm-hmm. Eyes are different eye movements or different visual field disturbances. And then fast, again, is face, arm, speech, and time. So Be Fast is just an upgrade of fast, including balance and eyes or eye movement or vision. Mm-hmm.
Stroke, we hear, comes in varying degrees. So we hear the term mild stroke versus severe stroke. Are those really accurate ways to portray it, or do they have it right on the mark?
The unfortunate thing is that those are ways that everybody portrays it. And in fact, I'll go one further and tell you that a lot of people like to call things mini strokes, which is for me like fingernails on the chalkboard. A mini stroke doesn't tell you anything. But what you mentioned was a mild stroke or a major stroke, okay, or a reversible stroke. Those are really your 3 options here.
Okay.
Reversible is what we call a TIA, or a transient ischemic attack, where the symptoms came and then they resolved. Mm-hmm. You still need to go into the hospital even if they completely resolve, because your risk of a permanent stroke in the year ahead is about 5%. Yeah. So it's not negligible. Now, the other issues are mild stroke versus a major stroke. And that's really what the ER physicians and the neurologists work on, trying to decide whether that's a large vessel occlusion, dealing with a large territory of the brain that's damaged, or a small vessel occlusion, dealing with a very small area of the brain that's affected. Mm-hmm. The issue here is TPA is applicable to both conditions. But the thrombectomy, which needs to be done at a comprehensive stroke center in the city, has to be done on a large vessel occlusion. Now, we can identify that clinically by way of the NIH stroke scale, which is our clinical assessment of the patient, a scoring system, and we can identify it with a CT angiogram, which is what we can get in the ER. And so we can treat somebody locally with TPA and then process the imaging of the CT angiogram, identify that there was a large vessel blockage, and then facilitate that patient's transfer. And our goal is to do all this within 2 hours. It's called DIDO, or door in and door out. Okay. They come in, we identify, if applicable, we treat, and we identify that it's a stroke, and then we identify furthermore that it's a large vessel stroke, and then we get them out of the door to a tertiary care center so that they can evaluate for the possibility of a thrombectomy.
Dr. Michael Sauter, our guest this morning. Indiana Regional Medical Center is a primary stroke center. We've been talking about diagnosing and about treatment options. Unfortunately, there are cases where people will come home and somebody who has been home by themselves, they've suffered a stroke, and they're in really, really deep trouble now because the requisite quick response hasn't been able to occur. So let's talk about recovery from stroke and how people go about it, how IRMC helps to facilitate that.
Right. And in that regard, you have to take where you're at and say, well, how can we maximize recovery? And in that setting, that's where we really rely on our physiatrist, Dr. Shetty, and the inpatient rehab staff, that is the IRF, or inpatient rehab facility at IRMC, to try to accelerate their recovery. Because generally speaking, the maximum recovery is realized in the first 30 days, significant recovery in the first 90 days, and modest or marginal recovery from 3 months to 12 months. So you really have some time imperative there to really focus on recovery. And that's what the staff on the third floor of the hospital do so well in the IRF.
Yeah, that's one of the really important things. And I think one of the really neat things is that people in, say, 5, 10, 15, or 20 years ago, there were debilitating things that happened to them that really were permanent. There are a lot of reversible effects of a stroke now that probably weren't reversible in previous years.
Well, right. And the idea here is when you have a permanent deficit, the idea is to incorporate the professional leadership of both the physiatrist and the physical therapy and speech therapy and occupational therapy specialists to maximize their functional recovery. Yeah. You're not going to regenerate brain, but you can maximize functional recovery around the injury of the brain.
Yeah, that's really cool. It's a team concept.
It's a team concept, absolutely.
Yeah, and that's what being a primary stroke center is all about. So let's review what we've talked about here this morning. FAST, ReFast, and FASTER. Those are the three that you were talking about.
Right.
The three acronyms. The primary thing we need to do is make sure we get the treatment as quickly as possible.
Correct.
And 911 is your best option.
Always.
Because you're going to get the ambulance there.
Yeah.
And therefore, you're going to have professionals on scene.
Right.
Rather than you getting tied up at a traffic light or something. Absolutely. So those are things that need to be done. And then the various treatment options we've talked about. People want to know, where do I find information on this? How do I train myself so that in the future, if something should happen to one of my loved ones around me, I'm prepared? So how do we find more information?
A really good idea would be to contact the hospital and ask for our stroke coordinator. And the operators at the hospital can then connect you with our stroke coordinator, who can then go over some of these points of interest for what are you looking for, how do you respond, and what kind of treatment should you expect. These are all the kind of the early issues that you want to be confident about to justify your actions.
Yeah. No, I'm running short on time, but one of the things we have not talked about are preventive measures that will help us to avoid a stroke or at least lessen the chances that we're going to get a stroke. And we hear number one, blood pressure is the thing we hear most of all.
Absolutely right. It's not as sexy or as dramatic as the adrenaline rush you get from administering TPA, but it is more effective than anything that we as interventionists can do. And that is, just as you said, controlling blood pressure, the primary intervention. Mm-hmm. Keeping your diabetes under control so that you don't develop what we call vasculopathy. Keeping your cholesterol under control. And then exhibiting or redefining a healthy lifestyle so that you're walking regularly, keeping yourself physically fit, and maintaining your diet and your weight. These are all real important things to do in terms of lifestyle accommodations.
He's Dr. Michael Sauter. We think that stroke is going to affect us when we get up in years, but it can really affect anybody, can it?
Unfortunately, it can. And what we're finding is that especially with the COVID that came out, younger people were unfortunately suffering from strokes in relation to the hypercoagulable or inflammatory phases of the COVID infection.
Dr. Sauter, thank you so much for coming in to visit with us. We appreciate it so much.
My pleasure.
It is a primary stroke center, the Indiana Regional Medical Center, and it's a wonderful resource we all need to take advantage of and follow through on the advice that he just gave you and learn the signs and what you can do to help in the case of a stroke. It is the voice of Indiana County, WCC.